The first step in entry of a new renal trauma patient for the Tier 1 entry, which will be primarily the demographic data and basic injury data, is to go to the AAST Multi-Institutional Center website and pick the study. Then you go to New Subject in order to enter the patient's data. The first question on the New Subject state is, did the patient have a renal trauma with a renal injury greater than or equal to grade 3? In this case, we would say yes. If we said no, then it would bring up the page for bladder trauma. So this patient did have a renal trauma, and we'll go to the renal entry page. So I'm going to make up a patient here to illustrate entry. First thing is age. We'll say this is a 28-year-old, a male. You can place the patient's height in inches or centimeters, and this is primarily to calculate the patient's BMI. And so you could also just place the patient's BMI directly in here if you have this information available. For instance, you could put in 30 and eliminate these others. Doesn't matter, we don't specifically need the height and weight, we just need a calculation of BMI. So for this case, we'll say the patient's BMI is 24. The date of the injury, these will be retrospectively entered after their renal trauma is complete and will be identified from the trauma registry. So we'll say this patient was injured on April 9th. The time of the injury was sustained at 1:30 in the afternoon. The patient arrived at the same day, so this patient was brought from the scene to the emergency department, whereas some patients may arrive later on. For instance, they're transferred from outside hospitals. They may arrive a day later than the injury occurred, or a couple days later as they're transferred in for further management. The time of hospital arrival, we'll say this patient was brought in by ambulance and arrived at 14:45. Date of discharge, the patient stayed 6 nights. This is a relatively simple injury, so we'll say they were discharged on the 15th. The discharge status, they were alive on discharge. The program automatically calculates the length of stay and the ICU length of stay. This patient was in the ICU for 2 days for observation. You can also check unknown if you don't know the length of stay, but we'll say 2. The next section is the comorbidities. And also, was the patient transferred? This patient came directly from the injury, but you could also check yes for patient being transferred. These comorbidities are all readily abstractable from the trauma registry, and that's why they were picked. There probably are other really significant comorbidities, but they're much more difficult to abstract, and that's why we picked these ones. This is a 28-year-old, very healthy man that was injured mountain biking, so we'll say he has no other injuries. Trauma type, as I said, it was a biking injury, so we'll say blunt. And then it will give you the choices under blunt. You can always pick other and say something that's not quite covered, like crushed by refrigerator, etc. In this case, we'll say this is sports related because he was mountain biking. And we could add in also the mechanism for a little bit more clarity, which is very helpful. Mountain biking. The injury severity score, we'll say 22. This also should be gotten from the trauma registry. And then the other injuries. And we'll say that this patient also had a spleen injury on the left side and a grade 2 mild injury. But you can fill in all of these according to the concomitant injuries. Again, these are readily abstractable from the trauma registry. Did not have any vascular injury. However, we could certainly check off the injuries that occurred. Emergency room disposition. The patient could have died in the ER, went to the trauma ward. This patient had a severe kidney injury and was taken to the ICU for observation. And laparotomy. If the patient required a laparotomy, then the date of the first laparotomy would be come up along with the time of laparotomy. This patient was observed, and so no laparotomy. Was the abdomen left open? Obviously there was not a laparotomy, so that was no. If the patient had been left open, then we'd say the date of the final laparotomy, which presumably is when the abdomen was closed. Thoracotomy, the patient did not have a thoracotomy. And did the patient undergo angiography? So this patient did undergo angiography, and we'll say that they underwent angiography a couple days after injury. It's a little bit of a complicated case. We'll say they went on the 11th. They underwent angiography at 9:33 in the morning. Was angioembolization or stenting performed? So patients can obviously undergo angiography and just have the angio component looking for bleeding, but then nothing is actually, no gel foam and no measures are taken to prevent bleeding, or a vascular stent is not placed. In this case, the patient did undergo angiography, and then this list comes up. What vessels were embolized? So these are the choices, and these encompass the vast majority of choices, but always you could check other if the choice isn't in there. So you can always check other to fill in a description of what was done as well. In this case, the patient had very little viable kidney, only a quarter of the top of one kidney, and was leaking urine into the retroperitoneum, and we felt that this was an unsalvageable injury. And so the patient's entire left kidney was embolized to kill off the remaining small portion of kidney and prevent urine from being produced. And so the left main artery was embolized. Did the patient require another angiography? In this case, no. If we had checked yes, like the patient was bleeding and then underwent another angiography a day later, then it would bring up another loop of this angiography to talk about the specifics. So in this case, no. So which kidney was injured? We said this was the left side, and the patient also had a splenic injury on that side. And the renal AAST injury code. This is somewhat redundant. This has to do with these AAST codes, and this patient had a grade 4 injury. So this is the grade 4 injury extending through the renal cortex, medulla, and collecting system, since the patient was leaking urine. And then the grade of the left kidney injury, just the AAST grade, which is the same as this grading system. This is somewhat redundant, as I mentioned. The initial vital signs at the scene. The first ambulance, if this is available, and we'll say the vital signs were 124 and the heart rate was 98. Temperature was not taken in this case, but if it was, you could put this in. Glasgow Coma score was good at 15. The initial systolic blood pressure in the emergency department was 112, and the lowest recorded systolic was 112. Was not much different. The initial heart rate was 102. Glasgow Coma score was 15, and the patient's temperature was 36.9 in Celsius, but obviously that can be in Fahrenheit as well. Did the patient have a base deficit? This patient did have a base deficit that was done, which was minimal. Lactate also, and we'll say this lactate was also almost undetectable. The initial hematocrit, you can put in hematocrit or hemoglobin. In the emergency department at the draw was 38.2. The next section refers to how many blood products the patient received. And this is very important for a study because we're looking at developing a model for ongoing renal hemorrhage after renal trauma and predicting those patients that will have issues with continued renal bleeding. So this is really critical information. In this case, we'll say the patient did not receive a transfusion, so did not get plasma, platelets, or cryoprecipitate. Now, an important part of this is there are certain hospitals that participate in what's called TQEP, and this is extensive data about angiography and also about blood products. And so these hospitals have information available about these products in the first 4 hours. And so if your institution records this data or you're part of the TQEP network, then you should be able to fill this in. University of Utah is part of the TQEP network, but if you're not and you don't have this information in the trauma registry, you can put not recorded. In our case, the patient received no blood at all, so we're just put in zeros for all this. The renal injury management. Did the patient require procedural or operative kidney injury, management of kidney injury other than angio? And if we said yes, then we would get this long list of things that was done, and there's always an other in order to capture anything that was done that was a little different than these check boxes. And so in this case, we just did angiography, and so nothing was done. This next section reminds the person that will be downloading the CAT scans and relevant images, which images are going to be needed. This patient had CT abdomen and pelvis. They also had angiography images of the kidney. And the next questions go on to much more advanced questions that a trauma practitioner, like a nurse practitioner, PA, trauma fellow, trauma surgeon, urologist would need to answer because they require some interpretation of the clinical course of the patient. And this starts off with, did the patient develop abdominal compartment syndrome, and then goes downward. So this is the first tier of data entry that has to do with entering demographics and data that can be readily abstracted from the trauma registry. Now the final part of this portion is going down to here, and it's very important that you do not check complete until the entirety of the patient records have been entered. And so here you want to check pending. This will save the record and allow the trauma practitioner to come in and check some of these other issues, like did the patient have abdominal compartment syndrome, what was their clinical course, etc. So this is absolutely critical that you don't check complete, but you check pending at the end of a data entry of the first tier of data entry. So I'm going to check pending. So our trauma record has now been saved, and what I'll do is go back to the main page and show you the trauma record. In order to see the new subject that you just entered, you'll have to reload or refresh the page. So I'll reload the page here. So here the page has been refreshed, and you can see our new subject, a number. This is a de-identified number, and you'll have to keep a patient list at your institution that will track this number versus the patient's medical record number, date of birth, the patient's name, as well as the trauma track number in your trauma registry. This is very important so you can refer back if there's any questions about the patient's clinical course. And it will also be important to communicate with whatever practitioner will be entering the advanced questions, and also the person that will be uploading ultimately the radiologic scans once they also have been de-identified. So I just wanted to show you an example of a database that you could compose. It's a very simple idea. For instance, here we have the Utah database that we'll be using. We have the AAST MITC number, the patient's name, date of birth, medrec number. This is a theoretical patient. The trauma registry track number, and then you may want to keep something about the date of injury, something additional information just to make sure you have the right patient if there's any questions about the patients in the future. This will have to be stored in a secured manner, whatever your IRB stipulates for storage of patient lists for ongoing studies. Okay, this ends the first video on data entry, which is a Tier 1 entry based upon the trauma registry data about renal trauma, demographics, and basic injury characteristics. There'll be a second video talking about the advanced questions, and also a video forthcoming that talks about uploading radiologic images to the MITC site.